Let's start. Hello, everyone. Welcome to our first CentoTalk of our Biomarker series. Today's webinar is about how biomarkers transform genetic diagnostics, a success story with Fabry disease. Today's webinar is led by Dr. Tobias Boettcher, a neurologist and medical consultant for CENTOGENE. Tobias is an expert in lysosomal storage disorders and holds his board certifications in neurology. Today's key topics that he will speak about are diagnostic difficulties for Fabry disease, biomarkers in the diagnostic setting, lyso-Gb3 advantages and drawbacks, clinical cases and lessons for the future, and advanced diagnostics and precision medicine. If you have any questions, please enter them into the Q&A chat and we will refer back to them at the end of the CentoTalk. I will now hand over to Tobias. Welcome.
Yeah, Francis, thank you very much, and a warm welcome to all of you attending this webinar. So I hope you can get some more insight in this fascinating story of Fabry disease, but also of diagnostic, especially of biomarker usage in the diagnostic of Fabry disease. Some sentences about the history of Fabry disease. Fabry disease, or better to say Andersen-Fabry's disease, was first described by two dermatologists independently from each other. The one, Johannes Fabry, living near Düsseldorf in Germany, the other one, William Anderson from London. And what they described in 1898 were the dermatological signs of that disease, so-called angiokeratoma. Angiokeratomas are some little blue reddish spots, skin spots, so they don't have any pathological meaning, but these both guys described it, and this disease was named after them, Andersen-Fabry's disease. Mr. Fabry and Mr. Anderson didn't have a clue about the genetic background of the disorder. They had no idea about multi-system involvement of that disorder, and it took until 1947 when the Andersen-Fabry disease was described as a generalized storage disorder. Fabry disease is an X-chromosomal inherited lysosomal storage disorder belonging to the group of sphingolipidosis. And by pathogenic variants in the GLA gene, it leads to a deficiency of a certain lysosomal enzyme called alpha-galactosidase A. The frequency of this rare disease can only be estimated, it's said about or approximately 1 in 40,000 to 1 in 100,000 for classical male patients. If you have a look on newborn screenings, you will find much higher frequencies, up to 1 in 3,000 or 1 in 6,000. But please have in mind that in those newborn screenings, also a huge variety of atypical or variants are described, or variants which are disputed in the scientific community. The deficiency of the alpha-galactosidase A leads to a reduced breakdown of certain glycosphingolipids, especially one that is called globotriaosylceramide GB3, and this GB3 accumulates consecutively in various cells of different organs, and it leads to a progressive organ damage. If you are dealing with Fabry disease, you have to be not only very clever and smart, of course, but you have to be also very polite, because you have to deal with all of your colleagues. So as a neurologist like me, I have to talk, I have to deal with guys from internal medicine, with cardiologists, with gastroenterologists. I have to deal with dermatologists, with ophthalmologists, with ear, nose, throat specialists, all kind of medical colleagues. So Fabry disease is a real and a very typical multi-system, multi-organ disease, and it needs a multi-system or multi-organ team, a multidisciplinary team to care for the patient properly. because Fabry disease is not a trivial disease. Fabry disease, at least in the times when treatment was not available, was a fatal, life-threatening disease. If you have a closer look to the sketches here, these are data from pre-treatment times. And if you only have a look at the males, the survival curve of the males, then you can see that the median cumulative survival in Fabry males was 50 years. So to say, by the age of 50, half of the Fabry males were already dead. Even in females, the life expectancy was reduced median to 70 years, still 10 to 15 years less than the general population. This is not a trivial disease. This is a life-threatening, fatal disease. I talked about X-linked disease, and if you are thinking about your medical studies, or then you might have in mind that in the old textbooks there's still one sentence: X-linked disease means males get sick and women are only carrier. Is that true for Fabry? Definitely not. Can females develop symptoms in Fabry disease? Oh yes, they can, and they will. The penetrance for heterozygous patients in Fabry disease is approximately 70%. And this is due to the so-called lionization effect, the random inactivation of one of the both X alleles in every cell of the females. Compared to other X-linked diseases, where really women are only carrier, for Fabry that is not true. Women with Fabry disease can develop symptoms, they will develop symptoms. Of course, symptoms occur on average approximately 6 years later than in males. But the symptoms can be as severe as in men. In up to 43% of the females that's described as having symptoms as severe as classical males. Another problem to diagnose the disease in females is that only 17 to 67% of females show a decreased enzyme activity, which is also due to the lionization effect I talked about. Talking about genotype-phenotype correlation or association in Fabry disease is another very tough topic, because it's almost impossible. It's almost impossible to define a genotype-phenotype correlation. There are different reasons for that. One reason is, in Fabry disease, you got a very high proportion of so-called private mutations, which means that most families carry different mutations. Every family, they got their own mutation. Furthermore, you've got a very high degree of clinical variability within the same family as well as among unrelated families with the same mutation. So you never know by the clinical symptoms, whether it's really attributable to a certain genotype. Much more parts of the phenotype may also be due to non-genetic factors. And what is most importantly for the clinical routine, our daily clinical routine, is that many of the clinical features of Fabry disease are also frequently observed in the general population. The symptoms of Fabry disease are very general symptoms, unspecific symptoms. There is almost no symptom which is exclusively attributed to Fabry disease. For instance, neuropathic pain, abdominal pain, tinnitus, hearing loss, cardiovascular diseases, stroke, etc. These are diseases, disorders, and symptoms which you can find frequently in the general population. Talking about genotype-phenotype correlation, we have to talk about classical and non-classical phenotypes, because we are distinguishing those classical and non-classical phenotypes in Fabry disease Patients with a classical phenotype, they usually got undetectable enzyme activity. If we are talking about males, they got a pronounced GB3 accumulation in almost all relevant organ systems. The symptom onset is in the first decade of life, and the relevant organ complications they are experiencing already in early adulthood. While patients with a non-classical phenotype, they got a variable residual enzyme activity. Symptom onset and also organ manifestation is variable as well, and relevant organ complications, especially cardiac, renal, or cerebrovascular complications, arise from 4th to 7th decade. And what makes it extremely difficult, sometimes there are oligo or monosymptomatic causes possible in those patients. Looking at the genetic background of these different phenotypes, we have to discuss that in classical phenotype, you mainly got nonsense mutations. Many of the frameshift mutations are responsible for classical phenotype, or also consensus splice site mutations. Or if you got mutations which are related to the catalytic center of the enzyme, or which are resulting in a non-functional protein or a complete loss of the gene product, then you will have a classical phenotype. And there are some missense mutations which are also causing classical phenotypes, and those missense mutations are affecting residues near to the active site of the enzyme, or they are disrupting the hydrophobic core of the enzyme. The majority of the missense mutations are causing a non-classical phenotype. Also, some of the splice site mutations, also intronic or variants in regulatory regions, usually cause classical phenotype, and missense mutations which are affecting residues on the surface of the protein, they're also responsible for the non-classical phenotype of the disease. Why do we want to diagnose this disease? Just to know? No, it's not only just to know. In 2001, the first treatment was approved for Fabry disease. Enzyme replacement therapy. In the US has been one substance approved, and in Europe 2 substances in the same year. So Fabry disease belongs to the rare genetic diseases which we can treat, and we can treat it effectively. Just have a look at those sketches here. Again, a survival curve of a Fabry population before the approval of the ERT. It's a different population, and the median survival in this population was 60 years. Here you got a Fabry cohort, females and males. Just concentrate on the males. After approval of the ERT, males got a median survival of 77 years. So with ERT, you got a prolongation of the survival by 17 years, which is a very, very good quality of life. And that's why it's so important in our daily clinical practice to think about, to be aware of the possibility that Fabry disease can be the cause of a symptom of a syndrome, can be the cause for the disorder of a patient. With every index patient we find, you can be sure to find additional 5 cases, approximately additional 5 cases in the family which can be diagnosed. One of our real problems is that despite all the advantages in therapy, we have still a substantial delay in diagnosis from the onset of symptoms. Those numbers, with over 13 years for males and over 16 years for females, are still true. Ricardo Raisin from Argentine, he had a closer look in 2017 whether we could improve our diagnostic procedures. He compared 2 times from one time point from 2001 to 2006, the other from 2007 to 2013. There was no difference at all. We didn't get any better in diagnosing patients. We got better in treating patients, so time to treatment was improved, but the time to diagnosis didn't improve at all. And that's a shame. That's really a shame. What are the problems in diagnostics? What makes it so difficult to diagnose this disease? Of course, you have to be aware of the disease. You have to be aware of the possibility that there could be a rare disease responsible for the problem of your patient. Yeah. And there are some other problems, more or less technical problems. For instance, males with the non-classical phenotype, they usually have a high residual enzyme activity. So it's not very typical. Yeah? If you have a look, or if you let the enzyme activity measure. Further problem, females, lionization effect, I've already talked about. Yeah? Females often get normal enzyme activity, so they are affected. So it's very important that in females, the genetic analysis of the GLA gene is in first place. It's essential to analyze the gene first. You won't get all the females. You miss a lot of females, of affected females, if you only have enzyme activity measured. And another problem is the high frequency of newly diagnosed genetic variants. So you get a lot of patients with a variant diagnosed which is not known so far, which is not described in the databases. As long as it happens in a male, you still got the enzyme activity to make a decision whether this genetic variant has got a biologic, pathogenic impact or not. But what about the females, where you cannot use the enzyme activity? So that's the question now. Could a biomarker be a solution to overcome at least these problems in the diagnostics of the disease? Talking about an ideal biomarker, yeah, we are talking about a biomarker, about a parameter which is really precocious. Yeah, it should be identifiable in early stages of the disease. Yeah, preferably before organ damage occurs. An ideal biomarker should be diagnostic. Yeah? It should be able to confirm or determine the presence of the disease. This must identify only the affected people. Of course, an ideal biomarker must be approachable. So if you got a perfect biomarker, which you can only measure in cerebrospinal fluid, it's not really approachable, not in the long-term situation. It should be reliable, so it should be able to change in relation to treatment, for instance. It should be also reproducible, so it should be the same result measured in different labs. Economic, okay, it's important. Yeah, it should be a low-cost measurement. Prognostic value should be good to have a prognostic value also with your biomarker. Biomarker should be able to determine severity of the pathology, and if possible, it should be organ specific. So it's a lot of prerequisites for an ideal biomarker. This is only a selection. This is only a selection of biomarkers which have been tested in Fabry's disease, either for systemic organ involvement or for specific organ involvement like kidney or heart. Altogether, I think for the future, or in the future, the 3-nitrotyrosine and also the microRNA approaches might be useful, but so far by now there are still only they got a scientific approach. It's not an approach in the routine daily practice or patient care. What we got in Fabry disease is lysyl GB3. Lyso-GB3 is a soluble degradation product of GB3. It's also called globotriazyl sphingosine. And it has been shown by various groups, that it is elevated in the plasma of patients with Fabry disease. Here you got the males, here you got the females, and you can see it clearly distinguishes classic Fabry males from healthy people, also late onset atypical Fabry males from healthy people, and also in females it is able to distinguish the diseased patients, the Fabry patients from healthy people. So lyso-GB3 is a biomarker we got. Is there any connection, lyso-GB3 to the clinical course? Yes, it is. It has been shown that the individual lifetime exposure to lyso-GB3 correlates with the so-called Mainz Severity Score Index. That's a score, a clinical score to evaluate the organ involvement in Fabry disease. It has also been shown that lyso-GB3 levels in serum correspond to the GB3 burden in vital organs, and it has been shown that lyso-GB3 is a significant risk factor associated with important clinical events in the scope of Fabry, like dialysis, like renal transplant, like cardiac complications, or stroke, and even death. In a recent paper by Albina Novak earlier this year, she could show that lyso-GB3 levels are higher in patients experiencing clinical events. You can see it here for females, here for males. Yeah, so light gray bars, these are patients who did not develop clinical events, while the dark gray bars representing patients developing clinical events, and they got higher values of lyso-GB3. And even more, patients with higher lyso-GB3 levels and higher pre-treatment exposure to lyso-GB3, which means the longer duration of the disease before the diagnosis was made, they experience clinical events earlier. This sketch shows patients with higher lyso-GB3 level. So the dotted line gives you patients with lyso-GB3 above the median. The solid line are patients with lyso-GB3 below the median, and you can see that patients with higher lyso-GB3 levels, they experience their clinical events earlier. The same is true for patients with a higher pre-treatment exposure to lyso-GB3. What do we know about pathophysiology, or the role of lyso-GB3 in the pathophysiology of Fabry disease? We know that lyso-GB3 plays an important role in the vascular pathology of the disease. And it has been shown that lyso-GB3 is an independent risk factor for the development of the so-called white matter hyperintensities in males, and risk factor for the development of left ventricular hypertrophy in female Fabry patients. Let's have a closer look to the vasculature, especially to the cerebral white matter hyperintensities and the role of lyso-GB3. Looking at the pathophysiology of the vascular damage, you got a very complex situation. It's not the one and only, there is not the one and only reason. It's a complex situation. For instance, you got pathophysiological impact just by obstructive microangiopathy, by lyso-GB3 accumulation. The accumulation takes place in the smooth muscle cells much more than in the endothelium of the vessel, and it finally leads to an obstructive microangiopathy. But it's not only the obstruction, it's also a hypertrophy of the vessel wall and a fibrotic remodeling of the vessel wall, and it's endothelial dysfunction. Yeah, you got a release of pro-inflammatory and vasoactive mediators. You got an increased production of reactive oxygen species and via an NF-kappa B pathway, a decreased production of NO species, which is a decreased release of NO residues. And finally, you got a disturbed metabolic function and a disturbed autonomic regulation of the vasculature. So this is really intense influence of lyso-Gb3 on the pathophysiology of the vascular damage in Fabry's disease. We are using lyso-Gb3 as a biomarker. First, for diagnosis. Lyso-Gb3 can help us identifying relevant variants in the GLR gene, and it helps us by differentiation of classical from atypical disease courses. But we can also use lyso-Gb3 for treatment monitoring. Here you can see a comparison in lyso-Gb3 levels in classical male Fabry patients compared to male Fabry patients which this atypical or non-classical phenotypes with missense mutations. All these patients had frame shift or nonsense mutations. You can see that the classical patients got higher levels of lyso-Gb3. Lyso-Gb3, and that is what we know from the literature, lyso-Gb3 is substantially increased in all classical hemizygous males and all adult heterozygous females with classical phenotypes. In heterozygous girls, even with classical phenotypes, it can be normal for initially and also for a longer time. So there you have to be careful. Not every girl, Fabry girl, must have an increased lyso-Gb3. But especially for the confirmation of diagnosis in females, lyso-Gb3 is absolutely meaningful because we don't have the alpha-gal activity which we can measure in females. We can, but it doesn't say anything finally if it is normal. So lyso-Gb3 gives us the option to evaluate the biological meaning, the pathological influence of a given genetic variant in a female patient. And this is what I try to show you now by some diagnostic examples we are diagnosed here at CentoGene. These are two typical cases. One female patient born in 1987, another female patient where the birthday was not given. One was diagnosed for a transient ischemic attack, the other one for arrhythmia, left ventricular hypertrophy and proteinuria. The first female had the missense mutation in 317I2F, not yet described in the databases. So what would have happened if he didn't have the lyso-Gb3? This would be a variant of unknown significance, but by this obviously pathologically increased lyso-Gb3, we could say this not yet described, this so far unknown variant is a pathogenic variant. This woman has got Fabry's disease. Lyso-Gb3 proved the pathogenicity of this variant, and the same is true in that example. This patient had an in-frame duplication, again, not yet described in the databases, but increased lyso-Gb3, and this proved the pathogenicity of the variant. These are also typical examples the other way around. Two females, one born in 1955, the other one in 1961, one diagnosed for renal insufficiency, the other one for a stroke. Both variants not yet described in the databases, lyso-Gb3 normal. There's no other option than classifying these variants as a variant of uncertain significance. What does it mean for the patient? it's a tremendous diagnostic uncertainty. You got no chance in females to determine the pathogenicity of the variant. Maybe in that patient with a renal insufficiency, the treating doctors could perform a renal biopsy to have a look for GB3 accumulation in the tissue, but that's an invasive measure. So the only chance for the further procedure in those cases is family screening, especially looking for males with the same variant. And if you find male patients with the same variant and a clearly diminished enzyme activity, then you can reclassify this variant as likely pathogenic or pathogenic. And if you don't find any males in the family, then you have to wait that an additional male patient will be diagnosed with that mutation, which is not sure, because I told you about the high proportion of private mutations. Some other diagnostic examples. This is a male born in 2002. We got no clinical information, which makes it sometimes really difficult in the diagnostic procedure. This is a known nonsense variant, which we found. The alpha-gal activity was below the lower limit of quantification, and lysyl GB3 was highly increased. No doubt about this is Fabry's disease. Same variant in a woman born 1992. The alpha-gal activity was reduced compared to the normal value, 38% of normal value. This is, I would say, borderline. If you have a look in the literature, there are numbers given up to 30–35% enzyme activity of the normal in Fabry's disease. So this is a diminished enzyme activity, but it's not a clearly reduction that would give you no doubt about the diagnosis. But lysyl GB3 is increased, so no doubt in that case that Fabry's disease is present. But what you can also see, same genetic variant, gender-specific differences in lysyl GB3, and of course also in the alpha-gal activity. Further examples. Female, born in 1950, diagnosed for hyperhidrosis, arterial hypertension, cardiac arrhythmia, and a cornea verticillata. Cornea verticillata, this is the one and only symptom which is almost pathognomonic for Fabry's disease. Cornea verticillata you will find in Fabry patients and in patients with some medication, amiodarone, chloroquine, can cause cornea verticillata. But if an ophthalmologist finds a cornea verticillata in a patient, then it's highly suspicious of Fabry's disease. This patient got two genetic variants. The first one is the 143A to T, a massively controversially discussed variant in the literature. There are people saying that's a benign variant, not causing any Fabry. Other people are stating that it could possibly lead to late onset Fabry's disease. And there is no lysyl GB3 increase described with this variant in the literature. And then there was a second variant, not yet described in the databases, but it's a nonsense variant, so there should be a pathological meaning. And lysyl GB3 with an increase to 7 nanogram per milliliter proved the pathogenicity of the second variant. So very clearly, the second variant, is the essential variant causing Fabry disease in that female. Here we got a male patient. A male patient, again, we had no clinical information. And the alpha-gal activity was 77% of normal. no male would have symptoms, Fabry symptoms, with such a high residual enzyme activity. But he had a missense variant. He had the known missense variant, 92D2G, and he had an increase in lyso-Gb3. So there was no doubt that this variant has a pathological meaning. There was no doubt that this male had Fabry's disease. How can we explain this high value of alpha-gal activity? Maybe that he has already been diagnosed earlier. Maybe he is on ERT. We don't know. That's why we need clinical information. It's very important for a proper classification, for a proper diagnostic in the patient. Very interesting case, a male born 1996, diagnosed for acroparesthesia, hyperhidrosis, gastrointestinal discomfort. His enzyme activity was diminished to 22% of normal, and then the genetic testing was very, very special. The sequencing of exon 7 was not possible, suggesting a potential deletion encompassing exon 7, but MLPA analysis did not reveal any deletion in this exon. So the colleagues went back to the NGS data, evaluated it step by step, and the NGS data suggested a partial terminal deletion of the exon at that position, but the exact breakpoint of the deletion couldn't be determined. So we had a diminished alpha-gal activity, not a value for a classical phenotype, but a diminished enzyme activity, and we had a complete unclear genetic result. And here, lyso-Gb3 increased to 25 nanogram per milliliter, proved the pathogenic result of that genetic testing. And we could only say that the residual enzyme activity is too high for classical phenotype, but possibly that's a late onset variant, which has been confirmed by the lyso-Gb3 measurement. Next examples, female born 2012, diagnosed for acroparesthesias. New variant, not yet described in the database. Here we also measured alpha-gal activity in the female, diminished to 23.5%, and really highly elevated lyso-Gb3. So lyso-Gb3 proved the pathogenicity of the variant, and with such a value for lyso-Gb3, you really have to discuss the option of a classical phenotype in that female, because it's important. That's an 8-year-old girl. You have to be especially aware of all the organ systems which can be involved in the disease. This girl has to be followed very closely by the treating doctors. This male born in 1965, diagnosed for left ventricular hypertrophy and arterial hypertension, reduced enzyme activity, same amount as this girl before, and he had an intronic variant, an intron 4, which has not been described so far, but located in a close vicinity to a known variant in that intron. lyso-Gb3 increased, not that much, but increased, and so again, even in that male, with the borderline reduced alpha-gal activity, lyso-Gb3 proved the pathogenicity of the variant for sure in non-classical phenotype. These are some patients of mine which I'm treating for many years now, and this is very, very interesting for me, and I wanted to show the results or wanted to share the results also with you, because here you can see the differences in lyso-Gb3 in patients with the same variant, differences intra-family, inter-family, and also gender-specific differences. These are two families, mother and son, mother and son. This woman, all four of them got the same variant, a late onset, not purely, but almost exclusively cardiac variants, the 215M2S. The female born 1976 variant, no disease activity at all, no pathologically increased lyso-Gb3. The son, born 2005, no disease activity, but he is male, already a slightly increased lyso-Gb3 value. Another family with the same variant, the mother on ERT for neuropathic pain and with lyso-Gb3 values around the normal value of 1.8, and her son born 1990 also on ERT for albuminuria, and also here absolutely comparable lyso-Gb3 values. So 4 patients, 2 families, different genders, same variant and different lyso-Gb3 behavior. It's not only diagnosis, it's also treatment monitoring. You can use lyso-Gb3. So lyso-Gb3 decreases with enzyme replacement therapy and also with chaperone therapy, which is available since, or which has been available since 2016 in Germany. So lyso-Gb3 decreases, but it decreases to an individual level. So don't expect to lower lyso-Gb3 to normal. You won't get it. Yeah? Lyso-Gb3 decreases with therapy to an individual level. This is true for classical males, also females, but this paper is about males, classical versus non-classical males. Yeah, ERT reduces the lyso-Gb3 levels to an individual level. You can see again the difference between non-classical and classical. Classical males have a much higher lyso-Gb3 concentration. And again, 2 of my own patients, this woman has a very stable lyso-Gb3 levels with ERT for many years, no problem at all. This is a patient I recently met, and these are his lyso-Gb3 levels from 2017. It was quite stable, and then suddenly he got an increase in lyso-Gb3. And the reason was that he was put on a new therapy. He was put from ERT to the chaperone therapy. And I first was a bit, I said, okay, we have to have a closer look. We have to monitor and to follow this patient closer to see what happens with lyso-Gb3, what happens to the affected organs. But then with the next control, you can see again in not normalization, but he is back to his known level of lyso-Gb3. So also the new therapy is obviously working well. Let's summarize. Lyso-Gb3 is an absolute valuable biomarker in Fabry disease. And as I try to tell you, it is useful in diagnosis, it is useful in variant classification, and it's also useful in treatment monitoring. Problem is, it is not perfect. It's not the perfect biomarker, because we are lacking desperately. We are lacking long-term data on clinical outcomes in patients to achieve the reduction. We don't know. We don't honestly know whether a reduction in lyso-Gb3 in the long term is really useful for the patient in terms of clinical improvement in the organs. But therefore, to answer this question, we need prospective interventional trials. Difficult to conduct, but altogether, even it's not perfect, lyso-Gb3 as a biomarker for Fabry disease, it's definitely the best biomarker we currently got for the disease. We use it, so please use it too for your patients. And thereby, thank you for attending, and now feel free for your questions, for discussions. Thank you very much.
Yes, thank you, Tobias. That was very insightful. We will now move on to our Q&A session. So if you have any questions, feel free to put them in the given area. It looks like we already have a few. The first question that we have is, what is typically the earliest manifestation of Fabry disease?
Okay, that's good. That's important. That's not only good, that's really important. If you're looking at classical phenotype, and in the classical phenotype, the earliest manifestation is neuropathic pain. Neuropathic pain and also gastrointestinal discomfort. These are the two earliest symptoms which can occur. And early means in childhood. In those classical patients, neuropathic pain has been described in boys, median 9 years of age, girls 16 years of age, but there are single case reports with children with the age of 3, boys with the age of 3, with neuropathic pain. And also gastrointestinal symptoms are a very early symptom. And that points to the problem in diagnostic. Pain, abdominal pain in a child is such an unspecific general symptom. Yeah, if all children with abdominal pain would have been suffering from Fabry's disease, then we would have millions of Fabry patients. Yeah, and that is really the difficult problem, to find out those kids who are suffering from Fabry's disease with that general unspecific symptoms. So to answer the question, neuropathic pain, gastrointestinal symptoms are the most earliest symptoms in Fabry.
Okay, thank you for elaborating. The second question we have is, what is the clinical progression of Fabry disease, and is there a certain rule?
Yeah, there is a rule with a lot of exceptions, so to say. So starting this, as I just told you, starting this neuropathic pain, starting this gastrointestinal symptoms, in the classical phenotypes, you will have the cardinal organ involvement, which means nephropathy, which means cardiomyopathy. You will have in the around the third and fourth decade of life, later on in the fourth decade, then also stroke or transient ischemic attack. So this would be a typical disease course in a classical patient, starting with neuropathic pain, starting with abdominal symptoms, and then further on in the late 20s, early 30s, starting with renal insufficiency or with renal function deficits, starting with some cardiology problems with arrhythmia or even cardiomyopathy and cardiac insufficiency. Yeah, but it's completely different in the non-classical phenotypes. It's completely different there. You can start with, or you have your symptom onset much later, maybe in the fourth or fifth decade of life. You got certain variants leading to mono or oligosymptomatic courses, where you got only, for instance, only the heart affected, or not exclusively, but in the majority the heart affected, starting in the 50s, starting in the 60s. Yeah, it's much more complicated. Fabry is easy as long as you got to do with a classical male. Then it's easy. It's much more complicated with all the atypical and non-classical types.
Okay, thank you. We have a couple of more questions and we have some time to answer. So let's go ahead. Let me see if I pronounce this right. What is your experience with adverse effects regarding antibodies against ERT, especially IgE type against ERT? Do you have some patient management guidelines in these cases?
Yeah, how to explain that? So fortunately, I don't get experiences with adverse events during ERT due to antibody formation. So I'm treating now, let me just think about, I got around 22 patients with Fabry disease, 15 on treatment, on ERT. All of the patients are treated in home therapy. I got no problems, I got no adverse events. I can only report from colleagues and from the literature what I know. So antibodies, IgE type antibodies are more responsible for adverse events like anaphylactic reactions. So you can, what some patients need is a pre-treatment. So before you start with the ERT, those patients are getting steroids and those patients are getting antihistamine drugs. And if you do ERT, and either by home therapy or in the outpatient department or in the clinic, of course, you have to be prepared. You have to be prepared that a anaphylactic reaction can happen. So you have to have all the equipment to deal with such a reaction. But again, if you already know that if a patient has already had such adverse events, then pre-medication could be an option.
Okay, thank you. We have time for 2 more questions. Let's go ahead. Do you think that the endothelial involvement produces injury in the vasonervorum, and this is the reason of neuropathic symptoms, including the ictus?
Ictus, yeah. Not alone, but yes. So maybe would be a good idea. I have to talk to my colleagues to my left and to my right. Would be a good idea to have another webinar just about neuropathic pain and Fabry disease. I could talk for hours about that. The reason for, or the underlying pathophysiology for the neuropathic pain in Fabry is the GB3 accumulation. In fact, it's a GB3 accumulation in the so-called vasa nervorum, the vessels who are responsible for the blood supply to the nerve, but also GB3 accumulation in dorsal root ganglia. This is also important for the pathophysiology of neuropathic pain. In the vessels, the GB3 is not, as I told you in the lecture, there's much more GB3 accumulation in these smooth muscle cells of the vessel wall than in the endothelium directly. So that is what I try to explain with the slide. It is a very complex situation, a very complex pathophysiological process leading to the vessel damage by the accumulation of GB3. But definitely the vessels supplying the nerve with blood, vasa nervorum, if they are involved, this is one of the possible reasons for neuropathic pain. That's right.
Thank you for elaborating. I have a question. This is about a patient. It says, I have a 42-year-old male banker who recently developed burning pain on both lower limbs. He has neither abdominal nor hypertension. Could this be Fabry disease?
Never say no, but I would not be convinced, because 42-year-old male with symptom onset in a male in the 4th decade with neuropathic pain. It's possible, but I think there are other diagnostic options, other diagnoses have to be ruled out as well. If you, first of all, what I would do, first of all, you have to prove that it is small fiber neuropathy, but because small fiber neuropathy is the cause for the neuropathic pain in Fabry patients. So first of all, you have to diagnose the small fiber neuropathy, which is much more complicated because the routine electroneuropathy is normal in those patients. So you have to perform a quantitative sensory testing, or you have to perform a skin biopsy and have to ask the pathologist to measure the intraepidermal nerve fiber density. And if you can prove small fiber neuropathy and you won't find any other reason, then of course Fabry disease has to be ruled out. But it would not be my favorite and first differential diagnosis in that patient, but it could be.
Okay, I think one more question, that's it. We do have a couple of more. This is a good closing one. What is your opinion on lyso-Gb3 as a biomarker for Fabry disease?
I'm convinced of that biomarker, yeah, because otherwise I wouldn't give you all these slides. No, as I said before, it is not a perfect biomarker. So if you for instance, if you compare to lyso-Gb1 in Gaucher disease, yeah, this is a fantastic, almost perfect biomarker. So lyso-Gb3 in Fabry disease could not reach that level of perfectness of biomarker, but it is the best we got, and it really helps us. It helps us in diagnosis. It really substantially shortens the diagnostic way, especially in females with newly addressed genetic variants. Treatment monitoring, I have to admit, of course, in all my patients, I let lyso-Gb3 measure every 3 months, but just to get an impression, it can't. So you have it measured. Of course, you also have to have a look for the organ systems every year by staging examination. So it is not a do it or not. You have to do both. So for treatment monitoring, it can give you an idea, but it is maybe not that important. But for diagnosis, for proving pathogenicity of newly discovered variants, yeah, it is absolutely fantastic, and I'm absolutely convinced of this biomarker. And I can only say, use it, try it, get your own experience with that.
Okay, I have to elaborate on that question a little bit. What is your opinion on lyso-Gb3 versus or compared to GB3 as a biomarker for Fabry disease?
Yeah, GB3, we did GB3 before lyso-Gb3 was invented to the community, and GB3 is not only not ideal. GB3 you can't use it in the clinical practice, in the clinical routine. It is not sensitive enough, and you won't get the same result. So we have never been really satisfied with GB3, and the invention of lyso-Gb3 was a result of these experiences with GB3, either in plasma or in urine or whatever we try to do with that. So lyso-Gb3 is much better option.
Okay. Sadly, we currently don't have any more time for further questions, but please don't worry if we were not able to answer your question today. If questions were not asked anonymously, then we will get back to you via email. I want to thank Tobias and you, the audience, for joining us today. I'm sure you were able to gain further insights into how biomarkers play an essential role in the early diagnosis. I'm going to now launch a poll to receive your feedback on the webinar on CentoTalk. I would, or we would highly appreciate if you would take a few minutes to fill this out. Thank you very much for joining us, for listening, and have a great day.
Bye from my side.